Allah, and today we will talk about the different treatment options in COVID-19 and the available studies to support those options. Today is the 9th of April 2020. And of course, do not expect that I'm going to present high-level studies. No good randomized controlled trials yet that were published. Most of the studies are cohort studies, case series, editorials, and expert opinions. If you go to clinicaltrials.gov, you will find more than 300 different trials that are started throughout the world, 106 in Europe, 83 in China, and 65 in the United States. Only 3 studies were completed. One of them is on the safety and efficacy of hydroxychloroquine that we'll see the results very soon, hopefully. If you filter based on studies that are recruiting patients now, you end up having 90 different studies addressing different aspects of the disease treatment. And what we will be talking about is hydroxychloroquine, then we'll go to remdesivir, Lopinavir, and Ritonavir. We'll touch bases on Tocilizumab, then steroids, anticoagulation, and convalescent plasma. Starting with the hydroxychloroquine, as you know, it is heme polymerase inhibitor. It is also a zinc ionophore, and I think this is the effect that we are relying on in the treatment of COVID-19. Its relationship with the hydroxychloroquine has not been confirmed in COVID-19 yet. And the study available is on Medrex IV, which is a preprint site. The study was posted in the middle of March, and we have some feedback on the study. And other initial studies have shown positive results. The number of patients did not exceed more than 100 patients. So those are small study, and this is one of them. And they looked at 62 different patients, 31 in each arm. The controls were external to the study, and they looked at clinical improvement of pneumonia that was seen in almost 81% of the hydroxychloroquine arm and 55% in the external control arm. I could not find statistical significance posted. There is no baseline characteristics, and it has low number of patients. Critical cases were excluded from the study, and there is no confidence intervals posted. So I'm not sure about the result of this study. We're waiting to see official publication in peer-reviewed journals. We rely on the study that was published in the International Journal of Antimicrobial Agents, looking at hydroxychloroquine and azithromycin as a treatment option in COVID-19. The study was done in an open-label, non-randomized fashion, and looked at the hydroxychloroquine in one arm. They were supposed to put 32 patients in it, ended up with 20 patients only, compared to external controls of 16 patients. They looked at virologic clearance with daily PCR on nasopharyngeal swabs, and on day number 6, negative PCR was noticed in 70% of the hydroxychloroquine arm and 12.5% in the control arm with statistical significance, indicating that there is an association between hydroxychloroquine and viral load reduction. When they looked at the patients who were on combination of azithromycin and hydroxychloroquine, they found that 100% of those patients cleared their viral load. They had negative PCR on day number 6. The differences between the three groups were statistically significant, indicating that there is possibility of more pronounced effect when hydroxychloroquine is combined with azithromycin. And this is this is to show how the hydroxychloroquine and azithromycin on day number 6 showed 0 or negative PCR in those patients compared to 54% of patients on hydroxychloroquine alone and 12.5% of patients on no medication on the external controls. And this is a dosing study that is also done in China, and showed that hydroxychloroquine is more potent than chloroquine, and the effect is related to increasing dosages. The higher the dose, the more more inhibitory effect that was noticed. They were able, based on this study, to determine that the loading dose of 400 milligrams BID for 1 day, and then maintenance dose of 200 milligrams BID of hydroxychloroquine for 4 days would be a suggested course of the medication. Of course, you need to pay attention to the side effects of the medication, and especially with the prolongation of QT interval and the possibility of torsade de pointes. There are also toxicities on the liver, the WBCs with leukopenia and the retina. However, these studies are not clinical. They did not have any clinical outcome. We do not know if the viral load reduction is translated into clinical outcome. Therefore, it is difficult to decide where we're going to use this medication, but due to the lack of any other available options, we suggested to use the medication in severe cases. No compelling data in those categories. The non-severe cases make more sense. However, it's going to be limited by the supply of the medication, and hopefully we can see more strong, robust data very soon. It also makes sense in prevention, but we don't have data. There are studies now that have been conducted, and we're waiting the results. This is a study that was completed on clinicaltrials.gov, and we are waiting the results of this study. It is randomized controlled trial, but it's only in 30 participants for severe pneumonia, and they looked at the virologic clearance and mortality. If you go to clinicaltrials.gov and put hydroxychloroquine and COVID-19, you will come up with 18 studies that are looking at using this medication in different settings of the disease. And as I said, only one completed study, and the others were recruiting patients still as of April 9th, 2020. So the second medication is remdesivir. It's a nucleotide analog, so it is antiviral also there's another medication called favipiravir. It is RNA polymerase inhibitor. So remdesivir has been studied, or there's an ongoing study by the company that manufactures this medication, and there was a huge demand on the medication, so the company halted the emergency access to this medication, and there are multiple studies available at this point. I think total of 8 studies looking at remdesivir and treatment of mild, moderate, and severe cases of COVID-19. So I hope that within the next few weeks we will hear more about initial results of these studies. Some of those studies are well organized, well designed randomized control trials. For Lopinavir, Ritonavir, it is a protease inhibitor that is used in HIV patients, and what we know about it is based on the initial experience from China. That the study was published in New England Journal of Medicine, looking at a total of close to 200 patients. However, there was no improvement clinically for those patients who were on Lopinavir, Ritonavir as compared to control. So this is a negative study, does not support using Lopinavir, Ritonavir for this purpose. However, we still have 6 other studies that we're awaiting the results, and some of those are just newly started. It's going to be a while before we get something more about this medication. For Tocilizumab, or medications that targets the interleukin 6, it makes sense in patients with severe inflammatory reaction, what we call cytokine storm syndrome, and this might be indicated by the presence of high ferritin, LDH, CRP, D-dimers, lymphocytopenia, or troponin. We have used this medication, but on selected cases only with cytokine storm syndrome. There are more than 8 studies looking at Tocilizumab as a treatment option in those severe cases with severe inflammatory reaction and cytokine storm syndrome. Of course, the medication has been approved by the Chinese authorities. In terms of steroids as used as anti-inflammatory, the data is again in one of the studies that is using early low-dose short-term application of corticosteroids in patients with severe COVID-19. It is a single center experience in China. They have only 26 patients on the steroid arm compared to 19 in the controls. It is retrospective cohort, and they used methylprednisolone 1 to 2 milligram per kg for 5 to 7 days only. They followed fever and CT scan findings. No peer review yet or publication. This is available on Medrex IV. And another study looking at risk factors associated with acute respiratory distress syndrome. It is a retrospective cohort for 50 patients versus 34 ARDS patients. And they looked at mortality, noticed decreased mortality with hazard ratio of 0.38, good confidence interval of 0.20 to 0.72. This study was published in the JAMA Internal Medicine, and This is the Kaplan-Meier curve for the differences between the patients who received methylprednisolone versus no methylprednisolone days after admission, and you can see the separation in terms of overall survival. The study is a small study and contradicts of what we know already, that steroids may increase virus shedding in SARS-CoV-1, and for that reason steroids did not show much of benefits in previous experience. So this needs to be verified, and we're looking at those studies that are studying the effect of steroids in COVID-19. There are a total of 5 studies at this point, and hopefully soon we will get more information to see whether we should go that direction or not. Some of the institutions already accommodated using steroids for severe cases with high inflammatory markers. Anticoagulation is based on the fact that they noticed increased levels of D dimers, and as we all know, inflammation drives increase in fibrinogen, and also the virus itself through the ACE receptors may induce endothelial damage. This leads to disseminated intravascular coagulation, and it has been described that microthrombi were reported in autopsies. There are 2 studies looking at COVID-19 associated coagulopathy, and those studies, the one on the right side here, showed that 71 of non-survivors and 0.1% of survivors met the criteria of disseminated intravascular coagulation during their hospital stay. So those patients who did not survive had much higher rate of DIC during their course. And on the left side, the study that was published from China showed clearly that D dimers were much more elevated in patients who did not survive compared to patients who survived. So it is still not yet clear about the direction. There is bidirectional relationship between the immune system and thrombin generation. Heparin blocks thrombin, therefore may reduce inflammation, and in addition, heparin has an anti-inflammatory effect as well, and ARDS may increase coagulation and causes pulmonary coagulopathy. And in this study that was published in March 2020, it's an observational study. They just looked at those patients if they were on low molecular weight heparin during their acute phase, and they monitored the response. As you see, this is without any heparin, and the inflammatory markers indicated in the blue circles that continue to rise if no heparin was introduced, compared to decrease in the inflammatory markers. Not only that, but also you can see here the T cells in the blood declining along with the B cells. The B cells, the green circles, and the T cells are the red circles. You can see here on heparin, they continue to be at a higher level, indicating good immunity. And D dimers were increasing here, and the triangles here indicating that they came down to lower levels. Still, this is an observational study. It does not give a conclusion that low molecular weight should be widely used in those patients. But it is proposed that high dose intravenous immunoglobulin and low molecular weight heparin anticoagulant therapy for those cases, for those severe cases. And excuse me, in another study published in the Journal of Thrombosis and Hemostasis, they looked at sepsis-induced coagulopathy score. If it was more than 4, those patients were treated with heparin, and compared, the mortality in those patients treated with heparin was 40% compared to mortality of 64% in patients who were not treated in heparin with heparin. The D dimers that was elevated more than 6. Mortality was 33% in patients who were treated with heparin versus 52 if they were not treated with heparin. However, I think there is a problem with the utilization of prophylactic heparin in China. I'm not sure if this is systematically done on all those patients, and all those patients did not receive any prophylactic heparin. Anyhow, when they looked at the 28-day mortality, it was much higher in the non-users of heparin compared to users of heparin. Here we do systematic prophylaxis to all our patients. We need to see studies that looking at we use sub-Q prophylactic systematically in all our patients, and what we need is to see studies that are utilizing systemic heparin as a treatment dose for those patients when they have the high D dimers to conclude that yes, those patients may benefit from systematic full anticoagulation. In terms of convalescent plasma, it's only what we have, only case series. They been published in JAMA and the PNAS. Those included 5 patients here and 10 patients in the other study, and they showed, this is from the JAMA, they showed that there is improvement in the oxygenation, improvement in body temperature, and improvement in SOFA scores for those patients who received the convalescent plasma. There is a question about ACE inhibitors and angiotensin receptor blockers, whether they should be continued or stopped. The decision at this point is based on our understanding of the imbalance between the effects of the products generated by the ACE2 and the angiotensin 2, 3, and 4. At this point, we lean more towards continuing those medications if the patient is already on those medications. We do not stop those medications, and we do not start those medications with the purpose of alleviating the symptoms of the disease. We need further studies to understand clearly the effect of these medications in relation to COVID-19 cases. There are other molecules that are present there, and different studies are looking into those, and we will present those as we get the results of these studies soon. Please stay safe, and thank you very much for listening.